Welcome to the Shrink Down. Today, we're going to be talking about the relationship between mental health and our physical health. But before we get into our topic, we are going to start with our 4-minute faves. Who wants to start today, ladies?
I'll go.
Oh, Terry. All right, go Terry.
So mine is a Disney Plus new show that my fourth grader actually told me about and recommended, which is really cool because he just started doing this. Here's another plug. They have a subscription to the Week Junior, that kids news magazine that comes weekly. If your kids are anywhere between probably second and sixth grade, maybe, it's awesome. It comes weekly. It's not cheap. It's called the Week Junior.
I was going to say, what is it called
And
again?
it's
The Week Junior.
the Week Junior. So I guess this is sort of two faves. And it's kid-friendly, appropriate news. And it's entertainment, sports, global news, politics, sort of light. And it's really cool. And so my fourth grader 2 weeks ago said, can we watch this new show called Win or Lose? It's the first Pixar original series.
So Maddie's watching it.
Yes. It's called Win or Lose. It's about a middle school girls softball team. There's 8 episodes. All of them aren't even out yet. They released 2 per Wednesday. So 2 more are coming out this week. And the team makes it to the championship, but each episode is from a different person's perspective. So one is from the ump's perspective and his background story in the week leading up to the championship game. One is from a player's perspective. One's from a mom's perspective. It's so well done. It is so psychologically friendly. It's hysterical. It's well written. Our whole family's been watching it. It's called Win or Lose on Disney Plus.
Fun.
And it was really cool because my fourth grader was so excited to recommend a show that he learned about on his own. And then it's really good. So I think anyone of any age, I think even teenagers would enjoy it. It's really, really good. Win or Lose.
Well, that's good because it's always hard to find a show, I feel like, that your kids like and you want to watch with them. Like sometimes they're like struggling through a show that they really like and you're like, oh my God, this is
not this. This is painful. Right. This is
awesome.
great.
That's good. Maddie and Griffin were watching and they must have seen it come up. And I was making them breakfast and I was like, got pulled into it.
Yeah.
And I was like, what is this? They're like, oh, Mom, you are going to love this. And then at some point I was in tears and they were like, see, we knew you were going to love it. Anytime I cry, they're like, we knew you were going to cry.
Gotcha.
So yeah, it's really good. Yeah.
All right. So what else do you guys got?
I'll go.
Okay.
So I had a couple of faves this week, but I'm just gonna kind of narrow it down here. So this last week for Catholics, we started Lent. So and I mean, most of the people listening to this know what Lent is, so I'm not going to go into that. But the whole idea is like 40 days of doing something that the way that I describe it to my kids is to better yourself. Right. So there's a big kind of focus, or there is a perspective about like fasting, and that can feel very punitive to kids, whether it's fasting from things like food or alcohol or social media, things like that, like taking away of something. And so my oldest, Sam, it's like, I don't know, Mom, I don't know what I really want to do. And I'm not a big fan of doing something like I'm going to fast from broccoli, right? Like something that's like not meaningful. Right. So I have said to them in the past, you don't have to take something away. You can actually do something. And one of the things that we do every single Lent is we clean out our closets and then donate. So clothes and books and toys and things like that. So that's something that we've done every single year anyway, but he really wanted to like do something. And so he's like, I want to make myself stronger mentally and physically, which I just like loved. I was like, love this. Okay. So like, how are you going to do that? Like, what does that look like? Right. So he just like, physical is very easy for him to figure out. Like, I'm going to do like, I'm going to play basketball outside and I'm going to do these things, whatever. And so I was like, well, what are you going to do to make your mind stronger? And he asked if we could meditate, which of course, like, I know.
I love that.
So we are doing that every night together and we're going between 2 apps. So that's what I'm actually recommending. So the Hallow app is like a Catholic-based app. You guys have probably seen advertisements for it. Mark Wahlberg.
Mark Wahlberg. Yeah.
Is the big guy in it. And he's actually very good. And so that one, it is definitely more religious. But there's a whole meditation section on there, and they're anywhere from 2 to 5 minutes. So that's actually really nice. And Mark Wahlberg is excellent as a voice to listen to.
Oh, he voices it. Okay.
Yeah.
How do you spell it? You said Hallow. How do you spell it?
Hallo.
Okay.
and both of these are doing free trials right now, which is why I figured it's a good time to just might as well promote both of them, because you could always just do it for free and give it a try, whether you're Catholic or not. And then the other app that's excellent is Peloton. They have got a great mindfulness section, meditation section. And again, you can find really good kid-friendly ones that are anywhere from like 3 to 5 minutes in length, which I think is a really good place to start for anybody, but especially for kids. And so we've been doing that together every night, and it's been super fun. So,
Love that.
Awesome.
Those two little apps are good places to start. Yeah.
And I will throw in there too, the Calm app is very good.
I do like the Calm app too. I
yeah.
recommend that to families.
Yeah. And I
Like
recommend
patients.
that one to patients. And that one has a lot of celebrities. Like that one has like bedtime stories. Like Matthew McConaughey will like read you a bedtime story.
That's funny. I've never been in that section of it. Oh, that's funny. Okay. Well, there we go. Yeah. All right. Wilhelmina, what about you?
Yes. So you guys know what my favorite is going to be, because I started watching this in Charlotte. My good friend Erica. Hi, Erica. We recommend TV and movies all the time to each other. And we do these video messages to each other. And so she had said, hey, I just started this new show. She was like, it's called Paradise. And she said, James Marsden's in it, Sterling K. Brown. I'm not going to say anything else. She just stopped and she was like, just watch it. And she doesn't do that very often. She's sort of like, oh, it's really good. If you get a chance, check it out or whatever. But she was so like crystal clear. So I think I started it that day or the next day. I started right on her trip. And I was like immediately pulled in. And I really can't say much about it.
You can't.
Because there's a lot of twists and turns. And like, what I will say is James Marsden plays the president. Sterling K. Brown plays like one of his main guards or security detailed
Secret Service.
Service, thank you. And then each episode is like lost a little bit, where you kind of like what you were saying, Terry, with your show, where you get a backstory on characters. And so it gives you a little bit, flushes out the person, and then gives you another piece to the puzzle of what's going on. Every single episode ends in a huge cliffhanger where you're like, what?
Yeah.
And it reminds me of Alias. When I used to watch Alias,
Yes.
I would almost need to start the next episode if I was binging it, because it would just be like, no. I need to see what happens.
Yeah.
So I started on my own, watched 2 episodes, then stopped and said, Owen, you need to watch these. So when I come home, we can catch up or we can watch it together, which we are now. So
Tim and I are watching it as well.
Yes,
yeah,
it's on my list. It's on my list.
Hulu.
Really good.
Yes. I was about to ask what is it?
Yeah.
Hulu. Okay.
What episode are you guys on?
4. And
that's what we're on.
Okay, so we've been doing that thing where we finished one, and then I'm like, we just have to watch like 5 minutes of the next one so that I can then go to bed. Because it's like it ends on such a cliffhanger that you're like, ugh, I need to like get into the next one. So yeah, it's quite well done.
Were you taken aback? I'm not going to say anything, but Lauren will know exactly what I'm talking about. No, the shower. I was like, hello. Hello. That's it. That says nothing. You'll get to it and you'll be like, hello.
If you're watching our video, if you're not watching the video, Terry is flagging Wilhelmina to not say too much.
And Lauren, did I say too much?
No.
Did you know exactly what
we're good. Yes.
Yep.
Oh my goodness.
Vanessa, what is your fave for the week?
So I'm going to share. So we just got back from our trip. And so I kind of am in travel mode. So I want to do a travel tip and a fave. So if you're in the market for a new suitcase, so if you have one you love, do not listen, do not buy. But if you have one, if you're looking for one, for my birthday, I asked for an away suitcase because I was in the market for a new one. And I have to say, I love it. It's a hard case, which is different. I've never had one before. I definitely think it has its pros and cons, but I'll just say that this thing glides like I can't even describe it. And to the point where my husband went on a work trip and took my away bag, which I have now forbidden. I'm like, no. If you're going to travel, you take your own suitcase. And he was like, this bag is amazing. And I was like, yes,
Is
I
it a
know.
carry-on size or a checked bags? How big is it?
So they have different sizes. Mine
Yeah.
is a carry-on.
Yours
Yeah,
is a
so I have the
okay.
carry-on, but you can get full size. They have the full range. And so if you're in the market, I highly recommend. I have really good friends who travel a lot. Like we actually travel together. They had them, and I was like, I think I need one of those. So Away is the name of the suitcase brand. I also want to give a travel tip since we're talking about travel. So I travel a lot, and this past fall I went to Colombia for a week with just my carry-on and a small duffel. So
Impressive.
You
Impressive.
guys know would never be able to do this.
So you can. So I will say the thing that helped was it was hot there. So obviously we're talking
Yeah.
summer clothes. So obviously if you're not, but rolling your clothes is like a good way to get a lot in. And then also using packing cubes. I don't always use packing cubes when I'm doing a check-in or a carry-on, but if I'm checking my bag, I do use the packing cubes because I think it's helpful.
I do too.
And I'm like very scared. The reason why I do carry-on as much as possible and not check is because I'm frightened. I have a phobia, whatever you want to call it, of my bag getting lost. So I don't like to check a bag. But if I have to, I will put half of my stuff in the check bag and the half of my stuff in my carry-on so that if they do lose my suitcase, I still
You
have
still have things.
half
Yeah.
things. Yes. Which I tried to describe this to my husband. So we did a one check bag together and we each had our carry-on. We went to Europe 2 years ago. And I asked him, I was like, so what do you have in your carry-on? He was like, I have all of my pants and underwear. And I was like, so if they lose your suitcase,
You'll be shirtless, but
you'll be shirtless.
Well, but
I
you
was
know
like-
what? He's got fresh underwear.
He does.
What more
I
do
was
you
like-
need?
I was like, no. The point was to put half of everything into the check bag and the other half into the carry-on. So my tips are rolling your clothes, packing cubes, and then my Away suitcase, which I love. So that's what I have to say
packing
today.
cubes are a huge
I use
Yeah,
packing.
danger.
I use
Big
them in
deal.
my carry-on.
Yeah, I
too.
know you do. Like I don't always. It just depends. Like
Yeah.
it just depends. Sometimes I do, sometimes I don't.
Yeah.
But definitely for a check bag,
Yeah.
packing cube is the way to go.
love
It helps
them.
just everything organized, helps everything fit better. Yeah. Well, good. All right. So we are going to be talking today about the relationship between mental health and physical health. And this can really run the range, right? So we can be talking about anything from, experiencing headaches when you're stressed, right? Like our body feeling, physical symptoms when we are either anxious or stressed, and to the extreme, which would be, experiencing epilepsy that's psychogenic in nature, right? That's like kind of the extreme end of the spectrum. So who wants to start on our topic today?
So I will jump in and say that I brought the topic to the table because there was a recent study that came out about the connection between stress and the experience of a stroke, and how it's higher in women than men, and especially in this age group of younger women between the ages, I think they said it was like 27 to 49 or something like that, but the average age was 41 in this study. And the study stressed that's an association, not a causation. An association between higher perceived stress and the experience of stroke. And it was significant in women versus men. And so I had just kind of brought it to you gals in a text of going like, it feels like we're hearing and seeing a lot of this. And it's just, I just thought it was an interesting topic that, we discuss on our own all the time. In our clinical work as well as in personal life about, the idea that are people aware of what their stress is? I think that was the question that I kind of immediately thought of when I was reading the study and then actually kind of thinking about it is it's higher perceived stress, right? And stress is completely subjective. So we can't say that I can't say the same thing that's stressful to me is stressful to you and vice versa. And so the only way that they can get this data is by people's perceptions. And that to me is so interesting. And so what is it about women that they're perceiving? Are they perceiving or are they experiencing stress differently than men that's resulting in these physical manifestations? So that's kind of where I think this kind of started. And then we all kind of had different ideas, even in our texting about like how that presents itself and what it means and what you're seeing kind of in your personal life as well as clinical life.
And what I think about is one of the first things we were taught in graduate school about panic attacks, right? So, and that is still the
Yes.
case. When I talk to my PhD trainees at Rush, one of the first and the primary disorders they focus on when they're in training is anxiety-based disorders.
Yeah.
One, because anxiety is the common cold of mental illness.
Yep.
It has the highest prevalence rates, and it is much more easily treatable and managed compared to other psychiatric conditions, right? Like bipolar disorder, major depressive disorder, even. So it's definitely, anxiety is one of those things we know what to do with for the most part, both in kids, teens, and adults. And I remember, and this is still the case for most PhD programs, is really teaching graduate students what to do when they're encountering a patient or a client with panic disorder, because it's one of those situations that we're talking about where oftentimes it is misconstrued. Those physical cues are misconstrued as a heart attack,
Chest pain.
as chest pain. They're very it's a very physical somatic manifestation of the symptom profile. And oftentimes what happens is people experience those physical cues, they hone in on them. That actually, there's a bilateral or bidirectional relationship.
Right.
Because then they think, oh my gosh, I'm having a hard time breathing. My chest feels tight. Am I having a heart attack? What's going on? Can I continue driving my car? Should I pull over? That obviously then makes the anxiety worse. And it's sort of this vicious cycle. So I do think, and again, panic disorder is one of those disorders that statistically has very good remittance rates because we know how to treat it. But anxiety presents in a lot of different ways. And I think some people cue into that in different ways, some don't. And I also think this is probably another part of the discussion. It's very generation based.
Yes, it is. Yes, it is. I think what we are starting, what we're hearing based on, like Lauren, what you were saying, it's this message that is being repeated over and over from the studies we're seeing, from what is being shown in youth today, in older adults, is that mental health is physical health. Like mental health, speaking of bidirectional, that is bidirectional. So when our mental health, when we are anxious, when we have stress, when we have trauma, when we're holding on to shame, all of these things activate our parasympathetic nervous system. And when our parasympathetic nervous system is activated, this is our fight or flight reflex. This is meant for running away from tigers and bears, okay? And it's meant to be useful in the moment, short, do its job, and then you go back to like a regulated state. Many of us are living in a continuous state of dysregulation.
Heightened.
Yes. And this has been going on. I mean, think of the older generations. This has been going on for years and years. And what they now know too is that this is all stored in the cells, and then it is passed on. So it becomes epigenetics.
Genetic.
Yes. And so if you're like, I don't know where all of this comes from, look at your parents, look at your grandparents. And it's not a blame. It's like, this is in their DNA.
Right.
And so we need to figure out how to get into a state of regulation. So when people say like, oh, I know I'm so stressed, I need to work on the stress, I need to like relax a little bit more. It's not just that. It is literally figuring out how to stay regulated, which is slowing down, which is rest, which is taking time, slowing down, sleeping, walking for no reason in nature. It's everything that our society sort of like says, like, we'll do that when everything else is done.
But you said the most important thing. You said how instead of why. And in a lot of my therapy work, people get bogged down in the why. And they want to spend hours dissecting, analyzing why, exploring past history, past events. And I have often said, let's focus on the how first. There's time for the why, but you're struggling right now. So let's focus on the how you're feeling and how you can use different strategies to help yourself be more functional.
And I do think that when when they're focusing on the why, it can be helpful to acknowledge and say it's the way your brain is organized. Yep. It is organized in such a way so that you're primed for this response. Now let's figure out what to do about it. As opposed to like Terry is saying, to really kind of get bogged down in the why. There can be some support and help in doing that at some point, but figuring out sort of a approach that's tailored to that individual or to you, to figure out what you need, so that your stress isn't manifesting itself physically, I think is really, that's paramount, right, to everything else.
Well, I think one of the things is just even taking a step back from there is people being able to accept the fact that their physical symptoms are not medical, like in the sense of like, you're not having a heart attack. This is a panic attack. Or no, this isn't leftover, cognitive impact from your concussion. This is your stress now because you missed 10 days of school and you have 15 projects to do. And so I think getting people to the point where they can accept that this physical symptom that you are actually experiencing is not because of some medical issue, that this is because of a psychological issue that's happening.
That is impossible.
I feel like,
well,
that's one hurdle, right? And then the next hurdle then is, okay, now that you're here in front of me, I'm the psychologist, then Lauren, right? Then the next hurdle is getting them to then, okay, let's focus on what's happening right now and getting you over that next hump. So,
but there is such a medicalization to physical symptoms. That's always the first line. So there is, it's really complex, right? Because there is some truth to, if you're having a migraine, there is a medical treatment for that.
Absolutely.
And sometimes migraines are born out of a sort of just a genetic predisposition.
Absolutely.
And there truly is nothing behind it.
Yeah.
But sometimes migraines are promoted and brought on by psychological origins. And so it's like, it becomes complex, right? Because you do need to treat your physical symptoms.
Sure.
But it's like anything. If you continue to have a fever, you do need to figure out where the fever's coming from. Right. So if you continue to have a physical symptom, figuring out like, okay, is this just straight physical in origin? Is this sort of a genetic predisposition based on my makeup? Or are there things that I can do to sort of support prevention of the physical manifestation? And that's hard because if you're going to a medical doctor, which sometimes you really have to do, but that doctor is only promoting a physical or a medical treatment, then you're not necessarily going to become aware of other aspects that may be contributing to the presentation they're seeing.
And this is also where the generational thing comes in, because I feel like we see a lot of the older generation where, no, but I just think I need one more MRI. I need another X-ray because I'm still having this back. I'm still doing this. And they spend just so much time. And this is where the medical field needs to be like, hey, I think instead of coming in for another test, another scan, another X-ray, another diagnosis, I think you should see a therapist, because I think this is more like psychosomatic. But they don't want to hear that because then they think, well, then it's not real. And I actually
that's
had
the
a
hard
great
part.
And that's the hard part. And I had an experience with my mom where she was having some heart flutters. We spent almost 24 hours in the ER and hospital, and she got all these tests run. Ended up, the doctor came in and was like, everything came back normal. Like, you are in great health. My mom, and he said, but what that means is, and my mom bounced out of bed, got dressed. She was like, oh, I'm so relieved. And I was like, Mom, did you hear him? Did you hear what he said? And she was like, what? And she actually hadn't really heard it. And he actually did a good job. He was like, this is real. What you're feeling is real, but it is based on, how much sleep are you getting? Are you stressed? And he did touch on it, but even I was in the room, he was touching on it, and she still was sort of like, oh, good, I'm okay.
Able to explain it away.
Yeah.
And it's so powerful. When we were talking about this topic, the best example for myself that came to mind, what I've seen mainly actually just in my clinical practice, is PNES seizures, which are psychogenic non-epileptic seizures, which in a neurology clinic, 1/3 on average, 30% of seizures, once they do testing, are PNES seizures. That is a huge percentage. And like Wilhelmina said, they're real, they're experiencing them. However, when you medicalize something and people who are suffering need a place to go, and that's what I
Yeah.
think it comes down to, is that when people are suffering, they take comfort in a label, a name, a group to belong to, a place to go. And we don't have a lot of places to go when people are suffering. A lot of, it used to be you go to your church community or you go
Yeah.
to your community. And now
Yeah.
it's,
Yeah.
I'm struggling. Where do I go? I'm going to go to the doctor's office.
You know, it's interesting you said that, Terry, because I looked up, based on this topic, I looked up on our psychological association, the APA, the American Psychological Association, sort of their research on stress in America. And they talked about tailored treatment for women because women are more likely to internalize stress, which results in physical and mental disorders, right? Whereas men externalize it, they get it out of their body, and that actually works very well.
Yeah. They punch
But
walls,
yes,
get in fights.
right? Aggression.
Mhm.
But women tend to internalize, and the two tailored treatments they were talking about, one is connection. They said the
Mhm.
problem is women are also more likely than men to cancel their plans when they have social plans or things like that, right? It's a much more isolated existence now than it used to be. So connection and then rest. And that was the other thing they said. That's a tough one because as simple as these two treatments are, rest is one of those things that while it's profoundly productive, right? We also feel like we would need to explain it away. Like it's almost stressful to think about resting for stress.
Mhm.
And so we don't do them, even though there are readily available treatments that are free, connecting with others and
Mhm.
rest. We don't necessarily involve ourselves in the treatments that would actually work, which is kind of continuing the cycle of the physical and mental manifestations of it.
That makes sense.
That was interesting. Yeah.
Mhm.
Going back to what Terry was saying about the PNES group, like I think what actually complicates that and a lot of the things we're talking about is that there's
Mhm.
a good percentage of those patients that actually do have epilepsy.
Yes.
And so then it becomes, how do you tease apart, the true medical, right? Like we talked about, like the migraine is real, right?
Right.
And my rule of thumb for like when clients come in with physical pain is like, let's rule out anything medical. So I
Yep.
do say medical
Mhm.
first.
Yep.
And one of the
Yeah.
things that I've experienced that I think is just such a great kind of model for treating patients, especially kind of these high risk groups like cardiology, neurology, is multidisciplinary clinics. And
Yeah.
so when I
Mhm.
worked
Yes.
previously
Yes.
in the hospital setting, I was part of a multidisciplinary concussion clinic because that's another population where we see
I remember that.
a lot of psychosocial issues going on.
Yeah.
And I kind of mentioned that earlier, where we have a team who comes in who legitimately sustained a concussion. And I will say there were kids who came in who did not legitimately sustain a concussion, but that's a whole separate group, but who actually had a concussion, and was experiencing these long-term side effects where, we all know about post-concussive syndrome. It's a true thing, but these kids were actually experiencing, anxiety, depression, secondary to their injury, right? So they've
Yeah.
now been out of school for 2 months.
Yep.
They have a pile of homework and they just don't know how to get back. And so, that clinic had, because we were seeing that we were getting like, these are not just the kids who had a concussion, went to their pediatrician, and like their symptoms resolve and they go on. Those are not the kids that we're seeing. We're seeing the kids who the pediatrician's like, well, I don't know what to do with this kid because
He's checked out medically.
we've done all the
Mhm.
things. And so the clinic was, a medical, physician. So sometimes it was neurology, sometimes it was physical medicine, but, an MD, and then neuropsychology, which is where I came in to do the assessment for, cognitive, but also assessing for emotional, psychosocial issues. And then if we then we get together and say, okay, what do we think is going on here? And if we thought like, okay, there's some anxiety, depression, then we were able to call in Pete Psych, who would come in and then, meet with them. And it was just such a nice model because, like you said, Terry, like they, the neurologist is like, I don't know what to do with you,
Mhm.
And so when you have this group, and I think it
They have to
helps.
navigate those conversations with the
Yes.
kids and the parents.
Right.
And they're not
because
necessarily trained to do so,
Yeah.
Right.
which is
And
where
so
the
it helps to have,
yeah.
because then everyone can come in and say, okay, we've all discussed this. We've all, like, we're giving you this message. And I think it's helpful to hear that from multiple, medical professionals, saying to you, hey, this is what we think this really is. I think that message is better received that way.
Mm-hmm.
Because when people don't want to hear that, they don't want to hear it.
Yeah.
So like
They
I
find
think
lots of ways not to hear it.
so I think about, you have like maybe older generation that they're like, I'm not crazy. That's what I'm not
Oh,
crazy.
I know.
And it's
I
like,
know.
no, you're not crazy.
No.
Or you have, in that case, Vanessa, you have parents that are like, no, but I think this is a concussion. Let's fix it and get
So
my kid
invested
back
in
in
that.
school
Yes.
and back in their sport, and let's keep going. And you're like,
Mhm.
ooh, what this requires is maybe less and
Yeah.
going to take a little bit longer, but is actually going to be long term
Mhm.
the solution, not just
Right.
there's nothing quick about it.
I think it's hard. We've talked about this before, and it always comes back with being able to tolerate discomfort. It's like such a
Mhm.
hard concept for
Yeah.
it's hard for all of
All
us.
of us.
And so then when you've had something that you could describe as medical and to what you were both saying, sometimes there's an actual medical solution.
Mhm.
And you're
Yeah.
like, cool, we're done. Like I took ibuprofen, my fever's gone, and whatever the virus was got out of my system.
Yep.
That feels really good because you tolerated that discomfort for the period of time you had to, and now I'm all done. And when it doesn't go that way, I think it's honest for all of us to say, I get it. It's hard. I don't like being uncomfortable. Nobody
Mhm.
does.
And I would say
Hard.
on the other side of things, so Wilhelmina's saying people don't want to hear it, right?
Yeah. Right.
A lot of what I see in my practice is teens and young adults with very mild presentations, sometimes what I would call mild presentations of human traits, want
Human
to
experiences.
human experiences want a psychiatric label, especially ADHD and autism. And the mild, what's interesting is the mild presentations tend to have the loudest voices in terms of social media presence, TikTok, etc. And by definition, those disorders, if they reach a category, it is a level of disability. It is a functional impairment.
Yeah.
So when I'm talking about kids who have ADHD, these are kids who have ER visits due to their hyperactivity.
Yeah.
These are kids who have significant academic impairment.
Right.
These are kids who can't finish high school, certainly
Actually
not attending
impacting
college.
their functioning.
Yes,
Right.
impacting their functioning. Not like, I have a hard time getting my 2 hours of homework done.
Yeah.
That's not ADHD. Okay. We're looking for functional impairment. Same with autism. So individuals who are mildly neurodivergent are seeking a label and they don't want to hear that, well, sure, everyone's allowed to be a little quirky and everyone's allowed to have some of these traits. And some of what you're describing are very human traits, even coming back to the ADHD, like attention fragmentation, because we live in a world with 100 distractions.
Right. A million.
Is your presentation approaching a level of disability and impairment? Or is it annoying for you as a person to deal with? Because that's also how well can you manage sort of your quirks and human traits that you need to. And I especially think when it comes to autism, for people to seek out labels that might not necessarily reach the full diagnostic criteria is somewhat disparaging to those families whose kids have a very severe level of impairment, whose kids are nonverbal, who are self-injuring themselves. And when it comes to the acceptance movement, especially for autism, I think for mild type, level 1 type of autism presentations, that's fine. But for level 3, accepting your child injuring themselves on a daily basis, that doesn't work. And so there is things like ABA and other strategies that need to be helped. So I think on the other side of things, there's individuals who are actively seeking psychiatric diagnoses as a form of self-identity because they're at a stage of identity formation because they're adolescents and young adults, and they are using some of these psychiatric labels to formulate their identities. And we're somewhat over-diagnosing some of these things because younger people are seeking these certain diagnoses out in order to assimilate some of that into their identity, which for those individuals who have severe levels of those, I think we're starting to dilute, the diagnoses get diluted.
I'm thinking about a clip that is actually from Lauren, a show you recommended earlier this, I think it was this season, The English Teacher, maybe it was last year. And
when they're in the library.
I think it was in the classroom and she was like, That was really offensive to me because, as many of you know, I've just been diagnosed with asymptomatic Tourette's.
Yes,
And-
asymptomatic.
Spot on.
And
Right.
I think we
He's
circulated
like,
this with
"That
each other. We're
means
like,
you don't have symptoms.
Right.
So, I mean, I think what it goes back to what we were talking about, all of this, whether it's a diagnostic category or not, is it's subjective.
Mhm.
And so if you're experiencing stress or related symptoms, but I think we can call kind of a lot of these things like your experience of the world. If you're experiencing in a way that feels so overwhelming to you that all you can do is label it as something physical when it's not, or you're ignoring it, you're totally dissociating from the fact that you are experiencing any of this and it results in physical or psychological symptoms, or you want to be labeled as something. The thing that kind of unites all of those different experiences is that it's all subjective. And so I think the question is, how do you get more in touch with what your experience is? And if it's actually like, is this stress or is this something else?
and I wrote down because I was reading something and it was talking about basically being in this sympathetic, like this parasympathetic state, this dysregulated state for like constant for years.
Chronic. Yep.
Chronic, and what it can do. And some of these symptoms, these physical symptoms that are real, that are a result of this. And I was shocked. I think, Terry, I reached out to you and I was like, oh my gosh. And it was like headaches, migraines. Obviously, we mentioned that. Light noise sensitivity.
Yep.
Tightness in your neck and shoulders. I mean,
Oh, sure.
how many? Difficulty calming down. Feeling cold.
Oh,
I
that's
had a lot of
interesting.
feeling cold. Sugar and salt craving. So I think about people who are like, oh, I just really crave this, different things, foods. High blood pressure. This one was surprising to me. Polycystic ovarian syndrome, which again,
Wow.
women,
Yeah.
and we're seeing more and more of that these days.
Yeah.
Well,
There are
talk about
more
internalizing something.
Yes.
Wow.
Sleep issues. I mean, those were just a few. That wasn't even the full list.
Yeah.
And these are things, obviously, but people could just write those off. But these could be from just being in a chronic state of dysregulation. And over time, these will impair your functioning. Sleep issues, constant migraines. I know I started to have constant migraines after I had my kiddos, and I was waking up in the middle of the night. Do you guys remember this? And I was like, what is going on? Well, I ended up doing the medical field first and did just to make sure. And it was that I was clenching my teeth and I was grinding but so much
in the middle of the night.
And I was like, oh, and that's when guess what? Found that out. I went to see a therapist, still seeing her. I worked on focusing more on taking that rest, not just like, oh, I'll do it when I can. And guess what? It helped. I did get on medication for a little bit and it helped.
Yeah.
It helped.
It got rid of the migraines.
It did.
And here's something to complicate all of this even more, right? So how do you know what is what's causing what? There is some really good research coming out of long COVID over the last 5 years, as we are at the 5-year anniversary. There is some consistent research that expectation of symptoms and expectation of symptom severity predicts severity of illness experiences.
Interesting.
So if you listen to that list Wilhelmina just read, for example, and go, I check 5-8 of those. Once you develop the expectation of symptom presence and severity, you're more likely to experience it. So
well, I will say, and I know that we're going to do an episode on this at some point about the hot topic of perimenopause.
I was about to say that. I was like, that's all menopause.
I'm like, people are just ascribing themselves 10 out of 10 symptoms. And you're like, well, are you just maybe like,
when you expect to have symptoms, you're going to
become more in tune to like what is your
sort
body
of that
doing.
self-fulfilling prophecy and how much it's this delicate balance of what to pay attention to, what to take care of versus what to be mindful for and be like, I'm just going to be present focus. Because one of the two biggest predictors, Northwestern has a research lab of long COVID, of experiencing, like those long-term sequelae of continuing to have COVID symptoms long after, is loneliness is a primary predictor of long COVID. And so is self-diagnosis of COVID. And so if people
Fascinating.
have said, I think I had COVID and I think I'm going to test positive, and even those individuals who didn't actually have a positive test, but said, I think it was a false negative. Those are the two biggest predictors for long COVID. There were people in May of 2020. That's how long COVID became a term. It came out in May of 2020, which was only 3 months after COVID showed up on everyone's radar. People were using the term long COVID. So I actually think it's sort of like how we learned a lot about trauma from 9/11. I think we're actually going to learn a lot coming from COVID and long COVID presentations about some of these concepts that we're talking about.
That's
And what did
interesting.
COVID do? It increased isolation.
Yes.
I mean,
so yeah, part of that's then true.
yeah,
Right.
yeah.
Right.
I mean,
That's so interesting.
I don't know about like what I saw in my practice and just in my life, especially that older generation, that isolation was brutal.
Yeah,
I know.
Like brutal. They couldn't see their kids. They couldn't see grandkids. They couldn't see, like, and depending on their social,
they're the high risk group, right?
They're the high risk group, and depending on
go
their
to the
social,
store.
yes,
Right.
and like I know we got on Zoom calls. The four of us got on. We had like happy hour. We were doing that. I know I was doing some other. It was like we were able to still reach out. In fact, some of us didn't, like, we had a social impact, but maybe not as much because we utilized it. And then there are other people that didn't do that. And so they were alone or like with maybe their spouse for maybe a year. I mean, it's a long time. And I think a lot has come out of that.
Like, there was also like a range of people who were like, I'm not going to see anyone. We're not going to see anybody, you know, that because they were maybe already
scared,
like anxious
scared
people,
of getting
right?
it.
And they were scared and there was already some existing anxiety versus people who perhaps were like, you know what, I'm going to create this bubble with this certain, like X amount of friends. And we're just going to like, you know, hang out sort of thing. So they weren't isolating themselves as much. So I think some of that pre-existing mental health stuff.
Yeah, I was say there was something very convenient about it in a way, and that's, I mean, that really kind of speaks to what we're talking about in terms of stress and how you understand it. And so if you're saying, if you're utilizing it as a reason to isolate yourself from people, something like COVID, there could be other examples of that though, then it's much more likely that you're internalizing your experience of so many other things as well.
Especially as the strains started to get less dangerous, like right away, absolutely. Like people were dying, right? Like people were.
There was no test to take. There was no anything to do, right?
But then as the strains got less lethal, really, and it became very similar to the flu and things like that, which can be still deadly, of course, but you would see these people who were maybe just more anxious in general, and they would just be like, no, I still can't. And at this point, many people had COVID. It was like, it's okay. And it was you couldn't explain it. They just were still isolating. They were still not going out, not seeing people, and
subjective nature of their experience.
Yes.
Right.
Yes.
Yeah.
Oh, I feel like we could go on and on about this. I mean,
we definitely
could see this so much.
I think we touched on it. Yeah.
No, I did.
Yeah.
Any other thoughts on today's topic?
My one parting thought, well, I have many, but one would be, I think the expectation of 100% wellness is not reality based.
Right.
Whether it's 100% perfection of mental health, physical health, both. This idea that we can all hit 100 and figure that out is false. And that's not realistic. Not to sound pessimistic or like a Debbie Downer, but that expectation of itself is something that should be challenged.
I agree. Especially for women.
And I will also, I just want to like throw out, because I feel like we often say, okay, it's stress. So, okay, but then what does that mean? And here is what this means. If you're listening to this, or you feel like, you know, maybe this is what's going on. One, obviously make sure the medical is checked out. Then find a therapist. Find a therapist that, you know, that you can afford. So they take insurance if you have insurance. You make sure it's a good fit. And then meditation. Lauren, you just mentioned some apps, great apps. There's a ton of ways to meditate.
It's so
Take
simple.
more time. It's so simple. Take time to pause. Take time to feel your feelings. All feelings matter, and even the ones you don't want to feel. And the only way you feel your feelings is actually slowing down.
Right.
Like the people who go, 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 they're always scheduled. Sometimes that's an avoidance of feeling.
Mm-hmm.
And so the solution, if you will, is slowing down, just taking the time, meditation, all of these things which maybe don't sound fun, they don't sound glamorous, and maybe they don't sound like a quick fix. That's it. But though that's what you do if it's stress and what to do. These are
I'll
some
add
of
to
the,
that, putting your phone away, like
Mm.
staying off social media, scrolling, right?
Yes.
Like, yeah.
Yes.
Staying away from that too.
Read an
Yeah.
actual book,
Yeah.
call a friend,
Mhm.
Rest
see
and
your-
connection.
resting
and
connection. And
Yeah.
you know what? For older individuals, I saw a great clip with Jane Fonda, and she said the best thing older adults can do to have better physical and mental health, join local art classes. Like in their like park districts, because it doesn't require something physical. So it's not like but I can't do that because of my hip or my this or that. And it doesn't have to be anything. You can be painting, it could be knitting, it could be whatever. You meet people, you connect, you do something creative, you activate different areas of your brain. And they said that they have found that this is like such a great protective thing for like older adults, like retired adults. So I thought that was cool. Yeah.
That is cool.
Yeah.
Well, if you don't listen to us, listen to Jane Fonda then. All right.
There you go. Jane knows.
Jane knows. All right. Thank you for joining us today. Please join us next time on The Shrink Down.